Hello and welcome to Health, Wealth and Happiness. I'm your host, Dr. Sadiq. Today we welcome our guest, Dr. Quijada, Norma. She's an endocrinologist and she's joining us to discuss diabetes. Thank you for being here with us, Dr. Quijada.
Thank you for inviting me, Dr. Sadiq.
Tell us, what is diabetes? It's so common and so many people are suffering with that. Tell us, what is that?
Diabetes is a disease in the pancreas. The pancreas is the organ which is behind the stomach. So that the pancreas releases an important hormone called insulin, which is released into the blood. And insulin helps the body to utilize energy source, which is glucose, which is the primary source of energy in the body.
So actually, let's tell the general public that pancreas is the one which secretes insulin, and that is just behind the stomach, and that's a very important part of our organ. What are the causes of diabetes? How it happened?
Well, diabetes is, there are many causes. Number one, it could be, one is the patient does not create or does not make insulin, just like our type 1 patients. There's also one which has only a little amount of insulin, not enough to bring the blood sugars down. And there are patients also that might have insulin but not enough to keep the levels, sugar level better. And it's a lifelong disease.
It's a lifelong disease.
Yes.
So going back to the pancreas secrete insulin, and the insulin sometimes would not be sufficient, or we have insulin but it's not that effective. And the third thing is that maybe the insulin, we do have insulin but we do not have the receptors or the areas where insulin go and act. That has some problem.
Correct.
So that those are and you said it's a lifelong
disease.
My God, that's really. But we'll come back and talk about how we can. What are the factors which we can control, and what are the factors which we don't have the control on it? Is there any way we can tell our audience that where the diabetes is such that if we do some things in our life, we can actually control diabetes, or we can prevent diabetes?
Okay, so the factors that are not controllable are the medications that you're taking, such as steroids. Steroids can elevate your sugar, and some of those, and also patients who are getting some chemotherapy, okay? They're getting some sorts of diabetogenic or drugs that can cause diabetes. The non-controllable ones are genetic, environment. If you live in the United States, it's a risk factor already because our food portion is huge and big. Go to Europe, and their serving size is just like a dessert for us.
Oh. So for the audience, there are two types of one are preventable. You said we can control some things. We can control some things we don't have any control. So the controlling where we can control is the diet.
The diet.
You have to have a smaller portion.
Yes.
Not a bigger portion. And genetics is a problem. What are the types of diabetes?
There are two types. There is a type 1 diabetes, which used to be called juvenile diabetes. And these are the patients who are not able to make insulin. Therefore, for them to bring their blood sugars down after eating, or even during the fasting state, they really need the insulin therapy.
So that's type 1 diabetes is usually people used to call juvenile. Now they are calling type 1.
Type 1.
And the pancreas are not producing the
insulin.
So we are giving insulin from outside. And the type 2 diabetes is?
The type 2 diabetes are the patients who still have some insulin, but initially when they were diagnosed with diabetes, at least 50% of the cells in the pancreas are already gone. So only 50% capacity to produce the insulin. So that insulin amount is not enough to bring the sugar down after meals and during the fasting state.
So we give them then, so type 2 is like we do have insulin, but you said it is 50% less what we needed.
Yes, that's in the onset. But later on, as the patient gets older and they get heavier, then maybe, and you're causing a lot of insulin resistance, so that the oral agents, the tablets that you take for diabetes is no longer capable of controlling the sugars. Hence, those are the time that the patients would need insulin.
So tell us what different types of treatments you use in your practice.
In my practice, we use oral agents to bring the sugars down, but cornerstone in the therapy of any diabetes or any endocrine diseases is the patient should learn how to hydrate themselves. Hydration is important because Americans have a very nice quality of water, but they don't like their water, okay? So that's number one. Number two, diet. They have to stay. They can eat anything they like, just like the rest of the normal people who do not have diabetes, but to moderation. So you cannot overeat. So you can eat all the things that everybody does, but you have to have like at least lesser carbohydrates, which is starches, the pasta, and the rice. And then you have more of the lean meat, like chicken, pork. Pork is the other white meat. But, you know, and then the fish is good, poultry, and the beef. But it has to be lean. Lean, yes.
So what you're telling us that for audience and for patients who have diabetes, that you can eat anything. You don't have to cut down 100% your carbohydrate,
no.
But you have to be in moderation. Eat in moderation. That is the key. That's the most important point, is eat in moderation. You can have your ice cream, but
yes.
eat a little bit.
A little bit.
Little bit of everything. So as you said that lean meat, fish is very good. Any meat you are eating, make sure that it's lean. Make sure it's not a lot of fat with that.
Like the marbled steak,
Oh,
that's not good.
That's not good.
Maybe a little bit, just to to
But
quench.
I think going back to your point, which I think stressing again on that hydration is very important. Water, water, water.
Yes, but water alone is not enough nowadays.
Tell us what you recommend.
So what I do with my patients, and everybody who is under my care would tell you that at least for a starter, I would ask them, depending on the age and the surface area of the patient, that my average would be at least 4 to 5 bottles of water a day, meaning 2 liters to 2.5 liters of water a day. Now, especially during summer, you lose a lot of sodium or electrolytes through the insensible loss during the sweating mechanism. So I would tell them to make sure that every 16 ounce of water is with at least 3 ounces of electrolyte drink, like
any
electrolytes like Powerade Zero. The ones available in this part of the country is we have G2, which has a lot of sugar, but it's still better and tastes better than. And then you can also have Powerade Zero or Propel. There's also another one which is, I think some people like very much, is the Crystalite.
Can we just add some like lemonade and add some fruits in the water, and that will give you minerals also?
No, I think they're just good for flavoring. Yes, but you can do that, and lemon is also good for weight loss. Yeah. Just add it on a little bit, just a little bit, just a taste. But you really need to have the electrolytes and the water, because I will tell you, I can tell every patient who comes in, you did not have any electrolytes. Why? Because their sodium, I already have a graphic of their electrolytes, and their sodium starts to drop, which is not good.
Oh. So even for the person who does not have diabetes, Dr. Quijada is recommending that you should drink water, and at least 2 to 2.5 liters of water, and add some minerals or electrolytes in it. That will be helpful. I think that you either buy from the stores and add that in the normal water, your drinking water, or you can make your own.
Yes.
Put a little bit of added things like fruits or throw some.
Fruits are also carbohydrates. It's also sugar. So understand, pure fruit drinks, juices are also carbohydrates. They become simple sugars like glucose when in the end part of the metabolic pathway. So everything is to moderation, but for just hydration, a lot of my patients really like their water, that's fine, but they hate to put any more electrolytes. I said, well, that's the reason why in the marathon, the walkathon, they don't have any more waters, because somebody died because of severe hyponatremia and seized and died thereafter. Okay, so that's why everything, again, everything in this world, just like what our divine provinces used to say, everything in moderation.
Yeah, that's the key. Actually, everything is more. We should eat everything, but we should eat properly, a little bit, not like a huge. Let's see that. Is there any cure of diabetes? If somebody is diagnosed with diabetes, there is any cure, or we can just say, oh yes, you are done with this and you will have a diabetes all your life?
Well, there is no cure to diabetes, that is correct, but it depends on how you define cure. But there are patients, as long as they take care of their eating habits, they exercise regularly, unless they have already limitations over time that they cannot anymore exercise, try to keep a healthy diet, healthy activity level, and then you drink enough water, and if you're a diabetic patient, you have no business in not checking your blood sugars. Unless you're taking only metformin, one pill a day, because it's not supposed to give you hypoglycemia. But any diabetics of mine knows better that they have to be.
What do you see in your practice, that if a person is obese and like 240 pounds, and if he's hydrating himself well, he's exercising, you think that the pancreas, which were secreting insulin, but that insulin was not enough for a person who is 240 pounds, but that person now has dropped down to 140 pounds. You think that the need, now that insulin will be sufficient for that person, or still you will call the person diabetic?
I do have a lot of cases in patients that we send for gastric bypass, bariatric surgery, may it be sleeve procedure, which is very common now. If they lose at least 30, 40 pounds, like at least some of these patients are automatically being dropped off all their medications if they are oral agents, okay? The surgeon itself, before discharging from the hospital, would put them down because they're gonna get hypoglycemic due to the capacity of their stomach. So then most of my type 2 diabetic, as long as there are no microvascular complications, and then once they lose, say, 30 to 100 pounds, let's just say that, then they will have a lot of low blood sugar reactions for other mechanism post-op, okay? But we have to take them off their oral agents. But if they're on insulin, we give them at least 50% or 20% lesser of their dose. But going back to your question, can a type 2 diabetes become non-diabetic? Yes, if they could keep the weight loss down. Most of my bariatric surgery patients are now called IFG, impaired fasting glucose.
Oh, okay. So going back to the same question, do we have cure for diabetes? You can say, yes, we can cure if we have we do a good job with our bodies. A lot of time I've seen in my practice that people are like really overweight, obese, and then they drop I recently had a patient who lost like 90 pounds. The patient was on diabetic medication. Patient was also on cholesterol medicine and blood pressure medicine. So now this person is not on any medication.
Correct.
So going back to that, yes, we can control our body, we can control our fate in many times actually. So it's good that we should have watch ourselves what we eat.
Yes. In relation, addition to your question, Dr. Sadiq, if the patient, I have several patients who went for pancreatic transplant or islet cell transplant, they are insulin free now. So right now it's so hard because the problem with these patients who had a transplant already had end organ damage, like microvascular complication, like diabetic retinopathy. They already have neuropathy and nephropathy, of course. It's hard for me to downgrade them as like a type 1. I cannot make them say, oh, she's no longer diabetic, because there are already complications. So technically, when it comes to coding system, I would still call them type 1 diabetic, but diet controlled after transplantation.
I see. I see
Yes,
now.
yes.
So I think it's very important that we should pay attention to ourselves in an early time, early
Yes,
age,
early on.
early onset, so we have a better results. So we can cure, but not like at a later age when we already get affected by diabetes. Eyes get affected, kidneys get affected, and
Correct.
nerves get affected.
What is important really in the management of diabetes is the early diagnosis. The problem is if your primary care physician, I do have a lot of sets of primary care physician, but if the primary care physician just keep on giving, okay, diet, exercise, but then you have to be careful because now the American, the ACE, Endocrine Society is already giving you, if the A1C, depends on the A1C of the patient. So patients who have diabetes should know, number one, how are their blood sugars? At least you have to check your sugars. If you are on insulin 4 times a day, if you are on oral agents at least twice a day, but alternating, you know, one day we do before breakfast and before dinner, the next day is before lunch and before bedtime. That is a must. That is a requirement when they come back to see me, because otherwise I keep on teasing them. I'm very good with math. You don't give me your sugars, I can't help you. I don't have a crystal ball, okay, unless you have one and you can read it. But number 2, being a diabetic, you should know what your hemoglobin A1C is. It's really important. Of course, some clinicians will say, okay, but it depends. If the patient's chronic kidney failure, their A1C will always be perfect because they're anemic. Remember, when you're anemic, when your hemoglobin hematocrit is less than 10, or like say even worse, when you need a transfusion, your A1C will be better too, because it is hemoglobin.
Yes.
So you gotta be not anemic first. But again, being a diabetic, remember this. Know what your sugar readings are and what's your A1C.
So please keep a notebook for yourself and keep a record of your hemoglobin A1C and ask your doctor what my hemoglobin A1C. That is the very good test which tell us how much sugar particles are in your system for past 4 months. So it's very, very important. It is not on the spot one. It tells you the last 4 months sugar. And also check your sugar daily, or whatever your doctor advised them. That is very, very important to keep an eye on the sugar.
The checking of the blood sugar, there's already some studies, and even in the past, that the more you check your sugars, the more your A1C are better. It's always correlated. You don't check your sugars, you forget. It's psychological. Oh, I'm not a diabetic. I'm not checking my sugars today. But you really have to check your sugar.
How often you recommend your patients
to check blood sugars? I ask them, depending. If they are on insulin, I give them 3 to 4 times a day. If they are on a sliding scale of a short-acting insulin, then they have to know what their sugars are to tell themselves how much dose they're going to give before that meal is eaten. And then there's also a long-acting. We have a lot of new drugs right now, but a lot of patients are scared of insulin.
Yes, I see that. But I think, in my experience, I think if they are on insulin, there are less side effects.
Yeah, I mean, you don't have to worry about kidney function because that's really kidney friendly. The rest of the drugs are kind of expensive. So the cheapest medication in the world right now for diabetes is insulin.
And it's the best one.
Yes, we have the best one.
Tell us something that I have a question. If a patient is diagnosed with diet controlled diabetes,
Okay.
how long a primary care doctor should wait on this one before they recommend refer to the endocrinologist, or before they call them that now you should be on the medications?
Well, number 1, they have to take a look at the blood sugars. And if the patient's blood sugar are constantly over 150s, no matter what they do, and they will just tell you how frustrated they are. Some of them will say, I stopped eating already so that my sugar will, it's either the patient already frustrated with the sugar control, or both ways, the primary care. But the main issue that would push primary care to send these patients to a specialist is when their A1C will never get back to, like, at least if they're over 7 or over 8. 7 depends if they are young, but maybe it depends. And also if they look at the sugars and they're so badly controlled, and then the blood pressures are skyrocketing, the cholesterols are off the wall. These are really important. And most of our internists in this area, most of our primary care are really good at dealing with their diabetes. But if the patients fight with the primary care just to get control, and they are both, either the patient or the primary care is frustrated, that's when they send. But I would tell you that it is better if you really, it depends also on the experience of the primary care. If he is not very keen, not really good with dealing with diabetes, I think the threshold of sending to a specialist is very low. So
I think for the general public, keep an eye on your own sugar, blood sugar. That's very, very important. And I tell often this thing that you are your own doctor. So you take the lead of your life. So that is very, very important. Can we prevent diabetes? Can we prevent? Give us some tips.
Okay.
Which can, for the general public, that some things, if we should not, we shouldn't do it, that can help us to prevent the diabetes.
How to prevent diabetes? It's I would say it's simple, but it's not easy to do. First and foremost, you just have to keep your weight as within the. Try not to be overweight. Overweight is a BMI of over 27. It's a BMI over 27 is overweight. For Asian, if it's over 23, you're overweight.
Really?
Because we have a lot of fat cells in our abdomen. So yeah.
Okay, so Asian over 23
is already overweight.
And for the general public,
let's just make it 24. What's your BMI?
I'm not gonna tell you.
Okay. Well, at least, but for the Caucasian, the American population, they use 27 as a BMI for overweight. So anything beneath that is good. If you can get down to the ideal body weight of for a Caucasian of 23 and 24, that would be lovely. But then you have to understand, as the population gets older, so is the risk of diabetes. Okay.
Oh.
Number 2, as the weight goes up, this is also increases the risk of your diabetes. Number 2, eating a high carbohydrate, high caloric diet, and can also cause insulin resistance. And over time, you're taxing your pancreas to keep on moving. Come on, give me more insulin to get my sugars down. I can't. And then the pancreas would just say, I can't. You overate too much. You overate and you just ate too much calories. So you do not, we call it glucotoxicity. You become a poison to your own pancreas. Too much sugar.
Too much sugar.
Too much sugar.
Weight control is very important, but on the second tip, which Dr. Quijada said, that you have to watch your calories, watch your sugar, what you eat. We'll be back after the break. Thank you. Welcome back. We are going to ask Dr. Quijada now, what are the symptoms of diabetes?
Symptoms of diabetes is when you have frequency of urination, significant weight loss, even if you're continuously eating regularly, patients who feeling so tired, or some visual changes, like I'm getting some changes in their visual acuity is also one of the symptoms of diabetes. And also, what else? Feeling hungry all the time, even though you just ate like an hour or 2 hours ago. Those are the symptoms. What else? That's the most common form, signs and symptoms of the early in the disease.
We should not ignore if we start losing weight unintentionally. If you're eating the same amount of food and you start losing weight, it's not like you shouldn't be happy about that. You should be concerned about that. And if you are having more, you still are hungry, and your appetite is not fulfilled by the normal 3 meals, and you should be watching that. Increased urination, that's very important. Feeling tired, these are important symptoms, and it's if you catch these symptoms early, go to your doctor, talk to your doctor about this, and check your blood sugar. That's very, very important. Tell us something about if the patient is running low sugar, what are the symptoms for the low sugar?
The early symptoms of hypoglycemia is or low blood sugar reaction is number one, the sweatiness. You feel your heart running so fast. We call it palpitation. Then you get some blurred vision, spacing out, like suddenly it's just like a petit mal seizure, like you just space out and you're not there. And then the ones around you would also see that your eyes are very glary and very shiny. That's one of the things that a family member would notice. And then also low blood sugar reactions in the early morning. That's why some people say, why do I have nightmares? It's probably the drug that I'm using. Nightmares, early morning or late morning nightmares are also very common in patients who have low blood sugar reactions. Anything that is, for a chronic diabetic who's known to have a lot of low sugar, some of them less than 60 milligrams per DL of blood sugar is already giving them the symptoms. To the chronic hypoglycemic patients who doesn't even know what that is, they also would present with seizure. Yes, and then that's why when the patient tells the primary care, you know, why is it that suddenly I get so tired and some blurred vision and sudden weakness and I feel like the life was taken out of me, but I just ate like an hour ago. Especially if you only ate carbohydrates for breakfast like bagels. Then yes, and then coffee and then orange juice. These are all carbohydrates. Definitely you're gonna get all those symptoms.
So at that time, if you're feeling having these kind of symptoms, please do not ignore. It is important that you should call your doctor and see your doctor as soon as possible, as low sugar is more dangerous than having high sugar, if I'm correct.
Correct, especially in the elderly population. Also, when the patient starts to be, I do see that in the office, like suddenly they get so cranky and they start hitting their wife. No, I'm not kidding, Dr.
Really?
Sadiq. They will start hitting their wife or hitting themselves. You know, those kind of weird symptoms and being crabby, and they just, I don't know, one of my patients would hit his wife several times. And the poor wife would call me, there's something wrong with him. And these are the weird, they are usually happening in a blood sugar of less than 40, 45, if they are so bad.
So
or
please,
unconsciousness.
Unconsciousness. So make sure that you and your loved one knows what the symptoms for the low sugar is. Make a list of those symptoms, put it on the refrigerator, and that way, you know, people will know that. We did talk about insulin a little bit earlier. Is this possible that we talk a little bit more on insulin, that all the diabetic patient should have insulin, or there are other treatments, or what is your take on that?
For insulin. Insulin is a must therapy, has to be a therapy for type 1 diabetes. Just be careful for the specialist. There is also that the type 1 diabetes happens in the children, which are in people who are less than 30 years old or younger, okay? And then they have no insulin. The problem you get in trouble is when you send somebody to a specialist and they are at the age of 70 or 65, they just diagnosed to have diabetes, and no medication, oral agents will not improve her sugars. Be careful, because there's a new form of an autoimmune disorder, a diabetes, which is called LADA, latent autoimmune diabetes in the adults. So they are type 1. They're considered type 1. They cannot be on any medication. So these are I'm just telling you some of the caveats. But those are the patients that can only have insulin, okay? Or survivor of pancreatic cancer, where all the exocrine and the endocrine part of the pancreas are all gone. So they need insulin regardless. So, but insulin is part and parcel of the treatment of type 1. But for type 2, you start with oral agents. Like we start with the metformin. Those are the first line drug, or you can use all other, or I don't want to go through that because it's more commercial. But these are oral agents that you can start. And as long as the patient keeps being very good at keeping their weight down, exercising, eating on time, good amount of proportion of carbohydrates to her protein content, then the other thing is they have to control their portion. What I tell them, start with not using the regular plate, use the
Smaller one?
the smaller plate, the salad plate.
Salad plate, okay.
Yeah, because then your eyes are gonna be, oh, I'm done with it. I must be full. Okay, so those are the
So
things. So those are the things that. But then over time, as I said, as the patient, because if they continue to gain weight, they continue not to change the way they eat. Oh no, I want my I want my pasta. I'm Italian, you know. So then, if they don't change, then it means that over time, the insulin toxicity goes up. The insulin resistance gets higher and higher. So you're basically burning off whatever cells of the pancreas that's left behind for you. Then that is the time that you really need to be on insulin.
So I think this is a very, very important point Dr. Quijada just made, that yes, on some cases you really cannot control without insulin, but in other cases you do have the control of your destiny. You really can watch what you eat, you can watch your diet, your weight, and so that then you don't have to be on insulin. So these are very important points that Dr. Quijada just made. So take the charge of your body, take the charge of your life. What are some complications of diabetes which people should be looking for or watching for it?
First, we're talking about the small vessel disease. Let's start with, we call it microvascular complication, which most of the studies have been geared at. These are diabetic neuropathy. So they present to the primary care, not initially with diabetes, but not with weight loss or anything, but they just come in with tingling sensations in their hands and feet, burning hands and feet. So this is called diabetic peripheral neuropathy. I guess for everyone who has seen me for the first time, when you diagnose a person with diabetes with the sugars already elevated, it means that they have had the diabetes at least for 8 to 10 years already. Enough time when they present to you, the nerves are already shut off.
Oh my God.
Because of the blood sugars that's really high, okay? The second complication is diabetic retinopathy. That is why in your patients, they should have a yearly ophthalmologic examination, a dilated eye examination. I think some optometrists can do dilated as long as they, but then you make sure that these specialists will send the report back to you. And if they don't show up for the appointment, to make sure that the primary care are informed so that they won't miss it, because that's how you preserve your eyes. Blindness can be sudden in diabetes. Sudden. Can happen suddenly, especially. However, the macular bleed is not very frequent, but it happens in the eyes, in the acute area of vision. That's the only time the patient will be symptomatic. But if they see their eye doctor regularly, that can be prevented over time. The suddenness is only when the sugars are so high or uncontrolled. So that's diabetic retinopathy. So you have to have a regular eye checkup on a yearly basis. Number 2 is diabetic nephropathy. That's when your primary care physician would ask you to give spot urine sampling for checking of proteins into the urine or microalbumin. I prefer to do the 24-hour urine sampling for my diabetics because I want to commit to the diabetic nephropathy diagnosis with a 24-hour urine. I mean, it's beyond any doubt, it's already there. So then based on these 3 main microvascular complications, we direct our therapy. Of maybe additional for nephropathy, we can probably start by giving medications for that, like ACE inhibitors or ARB. I know the primary care physicians are being scared or they are being advised by the health insurance that you're using the 2 drugs, but I always call them back because I always get a phone call. You're already giving ACE inhibitor, you're not supposed to give an ARB, angiotensin receptor blocker agent. Well, it's okay. As long as I'm following the patient every 3 months, I'm checking their kidney function. So that is on me. That's, really. So those are the major 3? Those are the microvascular complication. The macrovascular complication, which are big vessel disease caused by diabetes, is number 1, heart attack. Number 2, strokes. And the amputations are basically microvascular, but if they go up higher, meaning you're involving already the bigger vessels, that's how they have these kinking of their iliac arteries and all that. So These are the very common macrovascular complications of diabetes.
Oh my God! Did you? I'm sure that you heard Dr. Quijada's comment, and it's very scary. It is very important to take care of your health. It's very important to take care of your to keep an eye on your blood sugar, even if you are diabetics or even if you are not diabetics. I would recommend that you should have a yearly physical done by your doctor, and have at that time quick blood sugar test. It's not very painful. They can do by the finger stick and have it checked. And if you are having all those symptoms which we discussed earlier, any of those symptoms if you're having, please pay attention to that and go to your doctor. And they are very simple. Sometimes we ignore it. Increase urination, losing weight, we will be maybe happy, but we shouldn't be happy if there is unintentional weight loss. So pay attention to your body, and it's very, very important. Destiny is in your own hand. So we have to make a really, we should be committed to our body. Tell us some of, if you have any myths about some diabetes.
Okay.
What people have.
One of those is that eating sugar will give you diabetes. No, it's not, because it depends on how much sugar you're eating.
So that's, it means that I can...
You can have your sugar.
Okay.
They said that there is no treatment to diabetes. There is, and all diabetics will end up with complications. I would say no. It depends if you are not taking care of yourself. Oh, one thing, Dr. Sadiq, while we are in that topic of the complication, all my diabetics were told early on, even the first day that I see them, to take care of their legs. Because as I said before, the most common microvascular complication is diabetic peripheral neuropathy, which starts with the legs and the foot. That's how you get your foot ulcer, because there's not much blood supply already, and then you don't have a good sensation to your, because it's all burning. You cannot feel anything any more than if you have a big cut, you will not even know. So that is why I will always tell them, either the wife or the patient, to clean their legs from the knee down to the bottom of their feet every night when they retire, regardless of whether they have showered early in the morning or early in that day. Why? Because you have to make it clean, and you have to make sure you use mild soap. And then after drying your legs, going to your feet, you have to put cream, foot cream, or the very easy ones. We have a lot of Eucerin cream, they're cheap, and you just have to rub it from the knees down to the bottom of your feet, excluding the interdigital area, because that's really moist. You know, you just go through it. Make sure you don't have any ulcers. So in that way, you can visually see if there's any small cut that might be a start of gangrenous foot or something. So you have to look at where your hands are going as you massage your legs and your feet, and also make sure that you do not have a lot of thick calluses on the bottom of your feet, because that is where most of the ulcers are hiding, or the fungal infection starts. So the podiatrist should be involved early on in the disease, so that they will thin out that calluses. And so their feet, so if you tell me that all diabetics should lose their feet, no, it's not true. Because it depends. If you are not cleaning yourself, then fine, yes, that will happen. So these are preventable.
So there are a lot of things which Dr. Quijada today spoke about. They are preventable. You can prevent a lot of, you can even prevent the early on diabetes. You can lose weight, and also talking to your primary care doctor, take the charge, having a yearly eye exam, podiatry exam. You have a podiatrist who is involved in your care. That's very, very important. Diabetes is a very important part of your health that you need to pay attention to. Always be aware of your sugar, even if you don't have diabetes, in order to maintain your health. Diabetes is a very important part of your health that you need to pay attention to. Always be aware of your blood sugar levels, even if you don't have diabetes. In order to maintain your health, talk to your doctor to make sure you are doing everything you can to get your diabetes under control and keeping yourself as healthy as possible. I want to thank Dr. Quijada for joining us. Thank you so much.
Thank you. Thank you for inviting me.
Until next time, stay healthy, happy, and live better. Thank you.